Hello, welcome to week 5 content session. This is for NU 621, Advanced Pathophysiology. My name is Dr. Christy Burks. Topics we are covering this week are over the skeletal system, and we're going to look at several different ones in this session. So let's get started. First off, just to recap, the musculoskeletal system is very complex, and as we age, we lose bone mass, especially in women we tend to lose on average 50%, which leads to issues with deformity, pain, stiffness, and unfortunately a higher risk for fractures. So thinking of reasons age-related bone loss occurs in women, it could be genetics, hormonal factors such as decreased estrogen levels, decreased bone formation, vitamin deficiencies like vitamin D or magnesium and calcium. There could be underlying conditions such as malignancy, autoimmune diseases, even hyperthyroidism. Uh, Lifestyle choices such as smoking, alcohol intake, limited physical activity can play a part in that as well. And then we look at men's peak bone mass, which is related to their race and heredity, hormonal factors such as testosterone, their physical activity, and even their calcium intake during childhood. So as we age, height is lost due to that intervertebral disc degeneration. As we age, our joints and our muscles age with us. So joints decrease in range of motion related to ligaments and muscle changes. And those changes in collagen cause calcification and muscle stiffness. And skeletal muscle function is dependent on things which unfortunately are affected by this aging. And that also includes the nervous and vascular and even the endocrine systems. So the textbook states by the age of 50, approximately 10% of our muscle area is lost. And our muscle strength declines by 15% per decade in the 60s and 70s and doubles to 30% after the age of 80. So this week we look at different disease processes that will actually impact or involve the musculoskeletal system. First thing we're going to look at and talk about is gout. And there are um, a couple different stages of gout that we're going to look at. And the first stage is called asymptomatic hyperuricemia. In this stage, excess uric acid builds up in the body, elevating the levels of without causing any symptoms. In that second stage, acute gouty arthritis, and this is the symptomatic stage. The MSU crystals deposit in the joints, and these crystals are recognized as foreign bodies by the immune system, and that's what leads to the activation of those neutrophils and the release of the primary inflammatory mediators responsible for the inflammatory response, such as interleukin 1B. This when the triggering of the inflammatory response occurs, this leads to sudden onset of joint inflammation, that pain, swelling, redness, and warmth. And often we see it affecting the big toe first. After this acute attack resolves, the patient then enters what we call the intercritical period. And this period is just between acute attacks when the patient is asymptomatic. However, that hyperuricemia persists. So into the fourth stage chronic tophaceous gout, which recurrent attacks uric acid crystals deposits into tissues, forming tophi, which is the lumps under the skin. That's what can cause the joint deformity, and even we can see kidney stones start to form. In the chronic stage 5, it's called chronic gouty arthritis. This is persistent inflammation and joint damage from those tophi, leading to that chronic pain and disability if untreated. Now, the progression can be slowed or halted with proper treatment to lower that uric acid levels and help prevent further crystal deposits. So the primary cause of gout is that hyperuricemia. So we know that's the excessive amount of the uric acid in the blood. Hyperuricemia can result from overproduction of uric acid, decreased excretion of the uric acid, or a combination of both. So when uric acid leaves or levels become too high, the MSU can deposit in the joints and soft tissues, and that's what triggers that inflammatory response which is that characteristic of gout attacks. And that's what causes the symptoms, that redness, swelling, and warm joint and pain. Other symptoms you might see is fever, general malaise, and even fatigue. Now, some of the diagnostic tests that we look out for gout include the blood test to measure the serum uric acid levels. We may analyze the joint fluid to detect MSU crystals, and then imaging like ultrasound or x-ray to help look for that tophi or the joint damage. There are some complications of gout that you need to be familiar with. And the first one we talked about already is tophi, which is the deposits of uric acid crystals under the skin. And that's what's causing the disfiguring lumps. Joint damage, which that chronic inflammation and uric acid buildup can actually erode the cartilage and bone, leading to the joint deformity and disability. These people can also have kidney stones, which uric acid crystals can form stones in the kidneys or urinary tract. Chronic kidney disease with long-standing high uric acid levels, this may impair the kidneys' function over time. So that's something to be aware of. And then they also have an increased risk for heart disease and hypertension. Gout is associated with other metabolic conditions like obesity and hyperlipidemia. So again, proper treatment to help lower that uric acid levels and prevent those acute flares is very important to avoid these serious complications of uncontrolled gout. Next, we're going to get into myopathy, which myopathy is a process impacting the muscles and cause loss of functional muscle cells, impacting muscle strength, tone, and even bulk. So these agents are known to cause toxic myopathy. So there's agents like corticosteroids, alcohol, phenytonin, just to name a few, and other contributing agents like lipid-lowering agents and opioids, even such as heroin. Now, you can refer to box 44.8 in the textbook, and it breaks it down a little bit further, gives you further examples. Additionally, we look at endocrine disorders like Addison's, Cushing's, and hypo and hyperthyroidism that can cause toxic myopathy. Even infectious diseases like HIV, Lyme disease, and even influenza can lead to this. We're going to look at how alcohol causes toxic myopathy. So the direct toxic effects of alcohol on muscle cells play a major role. So alcohol impairs muscle protein synthesis. This increases oxidative stress and even that mitochondrial dysfunction within the muscle fibers and disrupts that electrolyte balance, all of which contribute to muscle injury, weakness, and atrophy. Nutritional deficiencies from chronic alcohol abuse can exacerbate the conditions, but the primary insult is the direct toxic effects of alcohol on the skeletal muscle. All right. Symptoms of alcohol myopathy include progressive muscle weakness, muscle cramps, muscle tenderness, and even difficulty with activities like climbing the stairs or getting up from a seated position. Severe cases can actually lead to respiratory muscle weakness, so that's something to think about as well. When we look at diagnostic tests, this include serum creatinine kinase levels. So we're looking at elevated muscle injury in this case, and then electromyography to assess the muscle fiber function. Sometimes a muscle biopsy is used to evaluate for necrosis and inflammation and ruling out other causes like nutritional deficiencies as well. There are some risk factors of toxic myopathy, which we talked about a few of them, but that muscle damage, we know from medications like statins, but others include the age over 65, someone that has hypothyroidism, anybody that has renal insufficiency, drug interactions. There's certain drugs that can interact that can actually lead to this, like cyclosporin or erythromycin. We talked about the high statin dose, and then the use of certain other medications like fibrates as well. So patients should be instructed to report any type of muscle pain, weakness, even dark urine, which could indicate rhabdomyolysis, which is that severe muscle breakdown. This is the early recognition and discontinuation of those offending medications can be very important to help prevent complications like acute kidney injury. All right, next we're going to look at degenerative disc disease, and this is a condition where the intervertebral discs of the spine gradually deteriorate over time. So the pathophysiology involves loss of the proteoglycans and water content in the nucleus pulpus, leading to desiccation and reduced disc height. This also weakens the fibrosis and increasing susceptibility to tears and herniation. So basically, the disc degeneration typically begins with that dehydration and loss of the proteoglycans in that nucleus pulpus of the intervertebral disc. The primary mechanism of pain in disc or degenerative disc disease is that inflammation of the spinal nerves caused by the disc herniation or the bulging or the degenerative discs impinging on the nerve roots or spinal cord. So for example, here in the image, which is from the book figure 18.17, it's an MRI. And if you look at the lumbar spine, it shows the stages, the first showing the disc is bulging and then the protrusion, and then you have the herniation. Now, the body part most affected is usually the lumbar spine, particularly between the L4 or L5, and then the L5 to S1 discs due to the increased mechanical stress. However, you can also see the cervical and thoracic spine impacted as well. Certain risk factors include aging, genetics, repetitive spinal loading, and trauma, obesity, and even smoking. Your clinical manifestations range from asymptomatic to chronic low back pain or that nerve root compression, spinal stenosis, and even decreased mobility. So the pain often worsens with activity and improves with rest in these patients. All right, now we're going to look at osteoarthritis versus rheumatoid arthritis. We know that osteoarthritis is an age-related inflammatory joint disease that is degenerative joint disease, which is mechanical. So it causes inflammation of the synovial joints where the loss of articular cartilage or degradation of cartilage and remodeling of the bone, sclerosis of underlying bone, and then the formation of bone spurs or osteophytes can cause those deformities as seen in here in this picture. And for figure, I believe 44.25. So in OA, the protein degrading enzyme stromatolin is commonly unregulated, contributing to that breakdown of articular cartilage matrix, or the MMPs. So the enzymes break down the cartilage matrix in osteoarthritis. The textbook material mentions that in patients with OA, enzymes like the stromatolin contribute to the breakdown of the articular cartilage matrix, and that's what leads to cartilage erosion and joint spacing narrowing over time. So that changes that occur in the subchondral bone in OA is that increased thickness in the formation of osteophytes, those bone spurs, and the development of cysts and sclerosis. So again, this image from the textbook, we see the ossification and deformity of the joint and erosion of the cartilage and the nodes formed by OA. The main risk factors for developing osteoarthritis include increasing age, which it's more common in older adults as cartilage wears down over time. Obesity, because that excess weight puts more stress on weight-bearing joints like the knees and hips. Joint injuries, so injuries from sports, accidents, or trauma can increase the OA risk later in life. Genetics, so certain genetic factors influence a person's likelihood of developing OA. Unfortunately, sex, so women are more prone to OA, especially after menopause. Bone deformities, so malformed joints or defects increase stress and wear and tear. And then certain occupations, so jobs with repetitive stress on particular joints can raise OA risk in patients. The most common cause of osteoarthritis is aging and just wear and tear on the joints over many years. Secondary causes include previous joint injuries, like we talked about, obesity, genetic factors, and those underlying metabolic or bone disorders. OA most frequently affects those weight-bearing joints like knees, hips, and spine, but can also be impacted. Some of the common sites include hips and hands, so hands can be impacted as well if you think about those repetitive motions as well. Clinical manifestations include that joint enlargement, pain, stiffness, limited movement or motion, and deformity. Treatment includes rest of the impacted joint to help inflammation subside, aerobic exercise, and range of motion exercises, and sometimes the use of assistive devices such as canes, braces, and walkers are needed. Weight loss is encouraged, balanced diet, and the use of analgesics or anti-inflammatory drugs to help with the pain. Other treatments are listed in the textbook and the supplemental PowerPoint for you to review as well. All right. In this image 44.3, it shows the joint lesions and the advanced RA or rheumatoid arthritis involving the femur. So RA, which is an autoimmune disorder where the immune system mistakenly attacks the body's own joint tissues. The exact trigger is unknown, but genetic and environmental factors likely play a role in this. The immune system produces autoantibodies like the rheumatoid factor and that target the actual synovial membrane lining in the joints. And this leads to chronic inflammation with inflammatory cells like lymphocytes and macrophages accumulating in the synovium. That inflamed synovium releases enzymes that degrade and erode the cartilage and bone within the joint. Now, the cytokine primarily involved in driving inflammation within the joints in RA is that TNFA, or that tumor necrosis factor alpha. The TNFA plays a central role in the inflammatory process and that joint destruction. So the immune cells that play a key role in the pathophysiology of RA are those T cells and B cells and those macrophages. The cells infiltrate the synovial membrane, leading to inflammation, pannus formation, and then subsequent joint damage. The clinical manifestations usually begin with inflammation, such as you'll see fever, fatigue, weakness, sometimes weight loss, and anorexia. Joints or generalized aching and stiffness occurs. And then over time, this results in joint damage, pain, stiffness, and loss of function. These joints can appear swollen and feel warm due to the inflamed tissue. Skin over the joint can look ruddy and red in color, or even cyanotic hue, which is a bluish purplish color, and thin, shiny skin. Additionally, RA can cause systemic effects like the fatigue and anemia, and inflammation in the organs like the lungs and even the heart. All right. Next, we're going to look at osteomyelitis. In this figure 44.18 in the book or from the book, it shows the different states of osteomyelitis. So osteomyelitis leads to bone necrosis through the following process. The invading pathogen provokes an intense inflammatory response, causing vascular engorgement, edema, and then small blood vessels thrombosis. The thrombosed vessels disrupt blood flow to the bone, depriving it of its blood supply and leading to necrosis or death of that infected bone area. And that's what's forming a sequestrum. The primary pathogen associated with osteomyelitis in adults is Staphylococcus aureus. Treatment includes antibiotics, sometimes surgery to remove hardware if that's involved, INDs or incision and drainage or irrigation and drainage, and the use of hyperbaric oxygen therapy sometimes is utilized as well. Risk factors for osteomyelitis include open bone fractures, bone surgery, diabetes, peripheral vascular disease, intravenous IV drug use, and being immunocompromised as well. Clinical manifestations typically include that localized bone pain that worsens with movement. Sometimes they'll have fever with chills, swelling, redness, and warmth over the affected area, drainage from that wound near the bone, limited range of motion. You can see fatigue and malaise, and then chronic cases, they have intermittent symptoms or a lack of systemic signs. That pain occurs due to inflammation and the increased pressure within the bone and potential nerve compression. So early diagnosis and treatment are crucial to prevent those complications like chronic infection or pathological fractures. Thinking of other complications, you can look at figure, let's see if I have this picture, figure 4419, showing a resected femur. This is from a draining osteomyelitis. So the osteomyelitis can actually lead to amputation and even worse, sepsis. So the next disease process that we're going to look at is called Paget disease. So next, looking at Paget's disease, which is the second most common bone disease after osteoporosis, according to the textbook, marked by an increase metabolic activity in bone characterized by abnormal and excessive bone reabsorption and formation, or that remodeling. So primarily affects the cortical bone structure, the outer layer of the bone, leading to disorganized bone remodeling, thickening of the cortices, and increased risk of deformities and fractures. So the trabecular or the spongy bone is primarily affected in the Paget's disease. And this disease begins with excessive reabsorption of the trabecular bone, followed by the formation of disorganized, weakened new bone. So the accelerated and abnormal bone remodeling process leads to the bone deformities, fragility, and an increased risk of fractures. Genetic factors associated with increased risk of developing this include mutations in the SQSTM1 gene, which is involved in regulating osteoclast function. Additionally, other risk factors include increasing age. So it's more common in as we age in older patients, 55 and older, male gender, and even a family history or genetic factors. It's more prevalent in certain geographic areas like Australia, Great Britain, and North America. And the clinical manifestations can include bone pain, deformity, fractures, hearing loss, headaches, and increased head circumference. However, many cases are asymptomatic and discovered just incidentally or accidentally. Complications depend on which bones are impacted or affected, but can include arthritis, neurological issues, high output heart failure, or even increased risk of osteosarcoma. So individuals with active disease, actually, the serum total alkaline phosphate levels are typically elevated, and then they have an abnormal X-ray that shows characteristics of changes like thickened cortices marked by tunneling, and that accentuated trabecular. So CT, bone scans, and X-rays can be used to confirm the diagnosis. Another marker is that serum plasma procollagen 1 in peptide, or PINP. So that is another test or marker that you can look for. So looking at osteomalacia. So osteomalacia, there's a defect in the bone mineralization. Well, osteoporosis is that reduction in bone mass and density. So in osteomalacia, the bone matrix osteoid is normal, but it fails to mineralize properly due to a deficiency of calcium and phosphate, and this leads to soft, weakened bones susceptible to fractures. So a direct consequence of vitamin D deficiency in osteomalacia is impaired calcium absorption from the intestine. So vitamin D normally enhances calcium absorption. So its deficiency results in that low calcium levels, preventing proper mineralization from or of the osteoid, leading to softening of the bones or osteomalacia. So vitamin D deficiencies in osteomalacia leads to increased parathyroid or PTH levels and hypocalcemia. The lack of vitamin D impairs calcium absorption from the intestines, causing the hypocalcemia. This triggers that PTH secretion as a compensatory mechanism to raise the calcium levels, resulting in secondary hyperparathyroidism. This results in bone pain, muscle weakness, and increased risk of fractures. So adequate vitamin D levels are very crucial for maintaining bone health and preventing osteomalacia. Now, in the next image, 44.3, it does list additional risk factors when we are talking about osteoporosis. So osteoporosis is characterized by that low bone mineral density caused by altered bone microstructure and leads to an increased risk of fractures. So the primary pathophysiological mechanism of osteoporosis is an imbalance between bone reabsorption by osteoclasts and bone formation of osteoblasts, resulting in the net loss of bone mass and density over time. So in the risk factors, we look at, unfortunately, being a female, advanced age, low body weight, being small boned, family history of osteoporosis, estrogen deficiency after menopause, low calcium and vitamin D intake, sedentary lifestyle, smoking, if you have excessive alcohol consumption, use of some types of medications like glucocorticoids, and then certain medical conditions like rheumatoid arthritis, hyperthyroidism, and even chronic kidney disease. Now, maintaining a healthy diet rich in calcium and vitamin D, doing regular weight-bearing exercise, not smoking, limiting your alcohol can all reduce the development of osteoporosis. So, let's see, I think I have a picture here. Yes, so in this image in figure 4411 from the textbook, it shows the osteoporotic vertebral body on the right compared to a normal vertebral body on the left. So you can see the differences in the malformations that occur. Now we did talk about the certain medications. So to think about that, particularly the long-term use of glucocorticoids like corticosteroids like prednisone, but even heparin, phenytonin, barbiturates, and even lithium. These medications can interfere with the bone formation or increase bone reabsorption, leading to that decreased bone density and increased fracture risk over time. So ensuring that our patients are aware and making sure that this is something that we consider when we're looking at medications. The textbook does mention how osteoporosis impacts over 200 million people. That's 79% are over the age of 80, and globally it causes about 9 million fractures yearly. So when we think of fractures and what is involved in the physiological process immediately after a bone fracture is the formation of a hematoma at the fracture site, providing a source of inflammatory cells and factors that initiate the healing cascade. So in the healing process of a fracture, those osteoclasts play a role in reabsorbing old bone at the fracture site to allow new bone formation. So one of the key roles of osteoclasts during the fracture healing process is the removal of necrotic or damaged bone tissue at the fracture site. This is necessary to help clear away so that way the new bone formation or by osteoblasts can occur. osteoclasts reabsorb and break down that old injured bone matrix through secretion of enzymes and acids. Really quick, looking at malignant hyperthermia. This is an underlying pathophysiological mechanism of muscle rigidity in malignant hyperthermia. It's the uncontrolled and excessive release of calcium from sarcoplasmic reticulum of the skeletal muscle cells. So the sustained elevation of the calcium concentration allows excessive stimulation of muscle contraction, and that's leading to the muscle rigidity. So in malignant hyperthermia, the trigger for the excessive release of calcium from the sarcoplasmic reticulum is exposure to the volatile anesthetic gases or the depolarizing muscle relaxant during general anesthesia. So the risk factors include genetic defects found in people who can develop malignant hyperthermia. There's a mutation in the RYR1 gene, and which encodes the calcium release channel of the sarcoplasmic reticulum in those skeletal muscle cells. Those mutations in this gene can actually lead to that dysregulation of the calcium homeostasis and predispose individuals to this issue, so the malignant hyperthermia episodes. Other risk factors include muscular disorders. So patients with muscular dystrophies or other skeletal muscle abnormalities are at higher risk. Children and adolescents are more susceptible compared to adults. And then, of course, having a close relative who experienced malignant hyperthermia increases your risk. So early identification of at-risk individuals through genetic testing and or careful medical history is very crucial to prevent these life-threatening complications during anesthesia. Rhabdomyolysis versus compartment syndrome. So in rhabdomyolysis, we see the rapid breakdown of muscle, which causes the release of intracellular contents like protein, pigment, myoglobin into the extracellular space and bloodstream. So the pathophysiological events that cause rhabdo involves the kidneys and coagulation syndrome and can lead to complications such as acute kidney injury. The release of myoglobin from damaged muscle can cause obstruction and damage to the renal tubules, impairing kidney function, and high levels of creatine kinase, potassium, and phosphorus from muscle breakdown also increase the risk of acute renal failure in this disease process. Additionally, the disseminated intravascular coagulation, or DIC, and hyperkalemia are also potential complications of rhabdomyolysis. So the release of the intracellular components from damaged muscles can activate the clotting cascade, and that's what leads to DIC. Additionally, the massive efflux of potassium from muscle breakdown can cause life-threatening hyperkalemia. Versus in compartment syndrome, which is the result of increased pressure within closed osteofascial muscle, fascial muscle compartment, which restricts the blood flow and leads to ischemia and tissue damage. So that increased pressure can actually result from bleeding, edema, external compression that compromises the limited space within the non-expandable fascial boundaries surrounding the muscle groups. So your clinical manifestations, think of your 5 Ps: pain, out proportionate to the injury, pallor, so that pale appearance, impaired altered sensation or paresthesis, impaired muscle function, and loss of pulse. The main complication, if compartment syndrome is not treated promptly, is irreversible tissue damage and disability. So delayed treatment can actually lead to muscle and nerve damage, contracture deformities, and potentially require amputation of the affected limb. When we look at musculoskeletal injuries, we have muscle strain, which involves overstretching or tearing of the muscle fibers or tendons. The pathophysiological mechanism involves the disruption of the muscle fiber structure, localized vascular damage, and inflammatory response. So the cellular process essential for muscle regeneration following a strain injury is that satellite cell activation or proliferation. And satellite cells are muscle stem cells that become activated in response to injury, proliferate, and then they fuse to form new muscle fibers or repair damaged ones. So signs and symptoms of that muscle strain include swelling, bruising, loss of strength, and even range of motion. Versus we have the sprain involves a injury to the ligament supporting joint. So your symptoms include joint pain, muscle pain, swelling, stiffness, and bruising. So sprains are graded. So the grade 1 is a mild pain, swelling, and slight instability, where you have grade 2, which is moderate pain, swelling, and include a partial tearing of the ligament, and then grade 3, which is severe pain, swelling, and gross instability or dislocation of the joint due to complete tearing or rupture of the supporting ligaments. Now we're going to look quickly at fractures. So the pathophysiology of fractures involves several different key events. So the first being injury causes that disruption of the bone's cortex, the periosteum, and surrounding blood vessels, leading to bleeding and hematoma formation between the fractured bone ends and beneath the periosteum. The second is bone tissue adjacent to the fracture site dies due to disrupted blood supply. So this dead tissue stimulates an inflammatory response with vasodilation, exudation of plasma and leukocytes, and infiltration of inflammatory cells and growth factors. The third is within the 48 hours, vascular tissue from surrounding soft tissues and marrow cavity invades the fracture area. Blood flow to the entire bone increases, and then bone forming cells in the periosteum and endosteum and marrow are activated to produce a callus around and between the broken bone ends. So those osteoblasts synthesize a collagen matrix that becomes mineralized. And then last, that remodeling occurs when unnecessary callus is reabsorbed and a new bone is formed along the lines of the stress to align with the host bone tissue. The healing process is very complex and it involves both the intramembranous and intrachondral bone formation, development of callus, and that eventual remodeling into solid bone. There are different types or several different types of fractures, so make sure you look at those. We have complete fractures, incomplete fractures, open compound, simple or closed fractures, comminuted fractures, and then know that fractures can also be classified by the pattern or direction of the fracture line, such as transverse, oblique, spiral, or impacted. So the location of the fracture, that proximal or intra-articular, is another way to categorize fractures when we're looking at that. All right, let's talk about bursitis versus tendinopathy. So looking first at this first image, which illustrates joints throughout the body impacted by bursitis or tendinopathy. Bursitis is that inflammation in the bursal sacs, which, if you remember, bursa are the small sacs filled with synovial fluid and are located between tendons, muscles, and bony prominences. So common sites of bursitis occurs in the shoulder, elbow, hips, knees, and even the heel. In this image, let me see if I've got that. It's got the Alcranin bursa, which is a fluid-filled sac on the back of the elbow at the bony tip called that Alcranian process. This acts as a cushion between the bone and tendons and the skin. However, when bursitis occurs that from repetitive trauma or overuse, even infection, it can have pain, swelling, redness, and tenderness at the site. I think I have an image of it. Let's look at it. Yeah, there it is. So versus when we think of, let's look at tendinopathy. So this next image shows what a healthy tendon looks like compared to tendinopathy. So tendinopathy is a term which is used to describe tendinitis, tendinosis, and peritonitis. We know that tendinitis is inflammation of the tendons versus tendinosis is that degrading of collagen fibers or disorganized of collagen fibers. And the term tendinopathy is just an umbrella term that encompasses all of those. So the tendinitis, tendinosis, and the peritendinitis. When we look at tendinitis, it's acute tendon inflammation. Tendinosis is the chronic tendon degradation or degeneration. And peritonitis is inflammation around the tendon sheath. So it's used to describe any painful condition occurring in or around a tendon. The pathophysiological mechanism of tendinopathy involves inflammation and micro tears in the tendon. So inflammatory fluid accumulates, causing swelling and thickening of the tendon sheath, which limits movements and causes pain. Micro tears lead to bleeding and edema and pain in the tendon surrounding structures. And with repeated inflammation, calcium deposits can form, resulting in calcific tendinitis. So the inflammatory exudate that develops after a tendon tear initiates that healing process where collagen fibers reconnect the torn ends. However, strong muscle contractions during healing can actually separate the tendon ends again, leading to lengthening or excessive scar tissue formation and even impair tendon function. Briefly, let's talk about the differences between dislocation versus subluxation. Dislocation is temporary but complete displacement of the articulating bone ends from its normal position in the joint. So this results in a loss of contact between the joint surfaces. In dislocation, the forceful separation of the joint surfaces can actually tear ligaments, tendons, muscles, and nerves, and blood vessels surrounding the joint as well. So the extensive soft tissue trauma leads to severe pain, swelling, deformity, and potentially neurovascular compromise. Dislocations often require reduction to realign the bones and repaired damaged structures. In contrast, you have subluxation, which involves less severe displacement and soft tissue injury. And this is a partial temporary dislocation where the joint surfaces remain partially intact, but the joint capsule and ligaments may be stretched or partially torn, but the articulating surfaces maintain some contact. Subluxations are often self-reducing when the deforming force is removed. However, they can still cause pain, instability, and put the joint at risk for repeated subluxations or a complete dislocation. The pathophysiology differs in the degree of joint disruption and associated soft tissue damage. Both dislocations and subluxations disrupts the joint stabilizing structures and can lead to long-term complications like the chronic instability, arthritis, impaired range of motion, and avascular necrosis if not properly treated. But dislocations typically cause more extensive acute trauma requiring that urgent reduction. All right, there are some main types of bone tumors you need to know. Osteogenic tumors, which arise from bone cells, osteoblasts, such as osteoid, osteoma, osteoblastoma, and osteosarcoma. There's also chondronic tumors arising from cartilage cells, chondroblasts, such as in osteochondroma, uh, and others that are listed in the textbook as well. And then you have collagenous tumors arising from the fibrous tissues cells that produce collagen, such as fibroma and fibrosarcoma. And then myelogenic tumors arising from bone marrow cells, such as giant cell tumor or Ewing sarcoma. Osteosarcoma is one of the most common malignant bone tumors in children, teenagers, and young adults, which is that osteogenic tumor arising from the bone cells. So benign bone tumors like the osteochondroma can occur in any age group, but most prevalently they're found in children and adolescents. Now, there are malignant bone tumors that metastasize from other sites, which are more common in adults or older adults. Ewing sarcoma is a myelogenic tumor originating from a bone marrow cell, and it's also seen in children and young adults as well. Okay, that concludes the content session for week 5. Thank you. I hope you all have a wonderful week.